Thanks, Gil and Bill, and good morning to everybody. I'll talk about another, unfortunately, fairly common complication we have with our patients, treating them with immune suppressive therapies with their infections. I'll talk about a couple of different topics. We'll think about identification, prevention, and treatment if these infections do come along. So I'll briefly touch on all of these topics. How often do infections occur, and what meds are the medications we really have to think about? Does combination therapy make it worse? It sure makes sense that it would. However, I'll show you the data and my take on it. What do we do about testing for tuberculosis? We have some new ways to look at it. And what do we do if it turns out to be positive, which is happening all the more often, it seems? I will very briefly talk about PML. I think natalizumab is still a medication we should keep in our armamentarium, and it's worth discussing at least briefly. And then talk about vaccinations. And I say new recommendations. They're not necessarily new recommendations, but new recommendations for me, as I've changed the way I think about giving live vaccinations to our patients, and we can see what you think. And then finally, we'll talk about preventing and treating varicella zoster, which is really tied directly to this issue of vaccinations as well. But what happens when your patients get shingles? And my guess is the majority of you have seen this in your patients on immune suppression. So how often do infections really occur on these medications? Well, if you look at all infections from the COMMIT study, they're not uncommon. We have almost 60% of patients who are getting some report of infections over the course of the study. I'll caution for saying that who knows how associated those infections really are with treatment, and we should really be thinking about the severe infections. And when we're talking with our patients about how often infections occur, I think talking to them about serious infections is the appropriate way. Thankfully, those rates are fairly low, and interestingly, if you look across studies, if you look at thiopurine monotherapy, anti-TNF monotherapy, or combination therapy, the rates are about the same. One might argue that the rate of infection is a little bit higher on thiopurine monotherapy, but it's a little hard to make that case. But nonetheless, you're not seeing this rate jump up with combination therapy, and I'll come back to this in a little bit. We just looked at this at our place in pediatrics, and Parambir Dulai just published this paper looking at the rate of serious infections on anti-TNF, immune modulators, and steroids in kids. And you can see here what we already suspect, that it's not the anti-TNFs and immune modulators that really is causing the big problem. It's steroids that are twofold higher than those initial estimates. Well, what about life-threatening infections? Of course, we don't want any infections to occur, but life-threatening infections are the ones we really want to think about, and think about who's at risk and how can we do anything to preemptively strike or change our patient selection. This is a systematic review we did a number of years ago, and we looked at the number of deaths due to sepsis that were thought by the authors attributable to infliximab in this case. The rate came out surprisingly high to me. 4 in 1,000 patients sounds like a high rate. 1 in about 250 patients dying from sepsis related to anti-TNF therapy, which just didn't sound right. So we looked a little more closely at these numbers. These were a pretty specific subset of patients who were getting into big trouble. These were older patients. If you look at the systematic review in general, the age was 63. If you look at the subset, which is the largest from the Mayo Clinic, it was 67. These patients typically had multiple comorbidities. They were on concomitant medications, including steroids and narcotics, and they had long-standing disease. I think long-standing disease is a really interesting point. If you think about your patients who are getting terrible intra-abdominal sepsis, these aren't the patients who are recently diagnosed when we're talking about early intensive therapy who have luminal disease. Think about the patients who come in with 10 years of disease, who have big phlegma, and you're not really sure what that is or if they have infection hiding in there. My bet, and I don't know that we've ever shown this, but my bet is that treating patients earlier is not only more effective, but probably a safer strategy as well. I'm not going to say that young, healthy patients are totally in the immune and clear or starting early, but really, when you're talking to your young patients, they're at a much lower risk of infection than we're talking to the subset of patients who are much higher. Okay, opportunistic infections. Bill, I'm sorry to say that I think this Mayo Clinic series was really misleading, and I think we've talked about this, and many would agree. The reason I think it's misleading is because when they looked at the combination of medications and the frequency of opportunistic infections, it was a dramatic increase from 2.9 to 4.5, and I'll give you that. I think a change from 2.9 to 4.5 would scare me away as well of putting two drugs together. But I think many people looked at this paper and thought, well, I'm not going to use combination therapy at all. It increases your risk of opportunistic infections, and opportunistic infections in general sound like a really bad idea. However, there are 2 points here I wanted to make. One, if you look at the types of opportunistic infections and the types that they reported here, the ones that I'm really scared of are the ones on the bottom, the ones that I actually don't really even know what to do about them. And not that I want any of my patients to get zoster or candida or herpes simplex, but the majority of cases reported in this series were actually fairly mild opportunistic infections, still defined as opportunistic, but not in the way that I would think about it. If you look at the others, they're really just a handful of cases that were reported. The other part of this is that if you look what drives that odds ratio of going up to 14.5, meaning a combination of any 2 or 3 meds, it wasn't the combination therapy in the way we use the term combination therapy. When we say that, we're typically discussing thiopurines and anti-TNFs, maybe methotrexate and anti-TNFs. But here there was actually only one case in the study of the combination therapy that we use. It was really driven by azathioprine and steroids. So I think this was a very, very instructive paper. I think the message, though, is using steroids increases your risk. And the use of combination therapy, in the classic way we use that term, really doesn't seem to drive that risk up much higher. And it goes along with what I showed you in COMMIT and SONIC, where the risk of infections was no higher, or serious infections was no higher when using combination therapy. So let's move on to the next phase of this, which is what can we do to help prevent infections from occurring? Both the AGA and the CCFA quality metrics look at trying to prevent infections, using HBV testing before initiating anti-TNF therapy, testing for latent tuberculosis before starting anti-TNFs, and then influenza and pneumococcal vaccinations. Testing for latent tuberculosis has certainly changed in my practice. We have choices now of using quantiferon gold testing or tuberculin skin testing. Quantiferon gold is nicer in many ways. It's certainly easier for the patient. It prevents that second visit to come back wherever they're going to get it read. There's a lower false positive rate, and that consistency between when you're immune suppressed or not immune suppressed, to me, is the most important feature here. Look at the blue bars. Those are the patients getting skin testing, whether they're on immune suppression or not on immune suppression, and you see a fairly dramatic change in the rate of positivity if you're on immune suppressive drugs. However, if you look at quantiferon gold testing across patients in both categories, it stays pretty much the same. And these are the subpopulation of patients we're typically dealing with. When we're starting anti-TNF therapy, in many cases, they're already on a thiopurine or already on corticosteroids. So they are immune suppressed, and I would argue that tuberculin skin testing really is an unhelpful test in that scenario. Not only is it more consistent, but that's actually been shown in at least one study to be cost-effective, and it is in fact recommended by the CDC. This I thought was interesting. I've been seeing more of these indeterminate positive results lately, and I'm not sure exactly what to do with those. But a recent study might have turned me on to part of the problem here, is that indeterminate results actually seem to be more common when patients have higher disease activity. So I'm going to think about that more often now in those patients who are indeterminate. Perhaps if I settle them down a little bit more with corticosteroids or wait a bit longer, it'll change. But you're stuck sometimes with these patients with these indeterminate positive results. You take a good, careful history about tuberculosis. They don't have any possible exposure that you can come up with. And do you either avoid anti-TNFs, do you treat them with INH, or do you just move on? And I think working closely with your infectious disease experts is important. So if they are positive, defined by a quantiferon gold that's positive or a skin test that's positive, my next step is typically getting a chest x-ray and a good history I should have written on there as well. I do work with my infectious disease experts, and they help me risk stratify patients to determine if we really need to treat them or not. And then before initiating anti-TNF therapy, in an ideal world, if they really are positive and you really are concerned that they have latent tuberculosis, ideally you can treat them for 6 months with INH, but I find that that's typically not practical. They're sick, that's why you're thinking about putting them on new therapy, so waiting 6 months usually isn't a fantastic option. 2 months is acceptable, but I would argue that sometimes you simply just have to do it, and at the same time starting anti-TNFs in patients who I think really need it and are at fairly low risk of tuberculosis, I would start them at the same time on INH therapy and anti-TNF therapy. I'll briefly mention natalizumab, as I think that it's still a very good drug, and although we have vedolizumab that takes PML, thankfully appears to be off the table, I still have a number of patients doing quite well on natalizumab, and some of our colleagues here in the audience probably do as well. What I talk to patients about is if they're negative, I think this is a very safe drug from a PML standpoint. If they're negative, I'm still checking their JC virus antibody every 6 months, and if it turns positive, I'll stop therapy. If they're positive, based on these results, that after a 2-year period of treating them, their rate actually goes up to 1 in 100 of PML. Based on that, I typically won't offer the drug. There are some scenarios where you have limited options, and if you're going to use it for a short period of time, say 6 months or a year to bridge them to something else, I think the risk-benefit ratio is reasonable. But in patients, when we're thinking about long-term therapy, if they are positive, I really think it's an unreasonable choice for these reasons. So here are general vaccination recommendations for immunosuppressed IBD patients. Then I'll come back to more specifics. Things you've heard before: annual influenza vaccination in IBD patients, pneumococcal vaccination in all IBD patients, then repeat 5 years later. Consider vaccinating all susceptible IBD patients at diagnosis before they're immune suppressed. It's impossible for you to know at the time of diagnosis if they're ever going to need immune suppression or not, so I would argue if they're not immune suppressed, that's a great time to think about vaccinating them right away before you immune suppress them. Perhaps take some of the vaccinations off the table or decrease the efficacy of the vaccinations, as I'll show you in a minute. I write new vaccinations about live vaccines, and I'll show you what I mean there. So this is something I'm just learning more about the pneumococcal vaccination. Perhaps somebody here wants to comment later who has thought about this as well. But there's this emerging idea of combination therapy, and again, a different type of combination therapy, using 2 different pneumococcal vaccinations. There's the 23-valent polysaccharide vaccine. That's the one we use. That's the one we're comfortable with and we typically give. It should be given to all patients, either who have high, low risk or planned immune suppression, and then once 5 years later. This 13-valent conjugated vaccine is really a super booster vaccine that really gets the immune system going. And actually, the latest recommendations that were just published just over this past week, actually, showed that perhaps you should give both vaccinations. You give one at a time, and either at 8 weeks before or at least 1 year later, give the 23-valent vaccine. I'm personally not doing this yet in my practice, but this is something that my infectious disease colleagues talk about. Actually, my rheumatology colleagues contacted me to ask if I was doing this. But the latest Infectious Disease Society of America guidelines do suggest this in immune-suppressed patients. So will vaccinations work in immune-suppressed IBD patients? Well, there are a number of studies that have looked at this with somewhat discordant results, but I think there's a message that when you're immune-suppressed, you're probably not going to respond as well, more so if you're on 2 drugs. In the first study, IBD patients were receiving Pneumovax, tetanus, influenza, and hepatitis and HIV on azathioprine or 6-MP monotherapy had a normal response to vaccinations. However, in the next study, adult IBD patients who were receiving pneumococcal vaccination had a poor response if they were on combination therapy. And then furthermore, pediatric patients who were on combination therapy had a decreased response to influenza. This is another point, too, that I find interesting, and it might be tied to disease activity. So as it turns out, in juvenile systemic lupus, a study was recently published on this, that the main predictor of lack of response actually had nothing to do with the drugs. It was due to disease activity. So I do wonder if those first 3 studies in some way are confounded by the fact that our sicker patients with higher disease activity are getting treated with combination therapy. It just makes some intuitive sense. It's biased by indication, really. Maybe it's the disease activity that we should wait to settle down and then vaccinate patients when they're quiescent or in remission to boost our immune responses. Well, let's talk about shingles now. This is, I find, and has been a problem for a while and continues to be a problem, but seemingly happening more often in our patient populations. We know that this is increased in IBD, and a case control study using the British GPRD database showed us that the incidence of zoster is about 1.5 times higher across the board in IBD patients, and then when immune suppressed on corticosteroids or thiopurines, it's even higher. What about the age? We know that this is a problem with increasing age, but an important point that Dr. Melman pointed out to me is that although the age in the general population where this typically is an issue is after age 50 or 60, if you look at the line where the IBD population, look at the darker bars there, starts to go up, it's actually quite young. We have 11 to 20-year-olds with a rate of shingles that's pretty similar to older patients who are not immune suppressed or without inflammatory bowel disease. So should we actually be thinking about immunizing our younger patients sooner, which really goes against typical guidelines or typical thought strategy for zoster. So varicella and zoster vaccines in immune-suppressed patients. I gave a talk on this here a couple of years ago, and I think across the board I said we cannot use these vaccinations if patients are immune-suppressed. In fact, we did a research study at our institution where we gave out a handout to patients that said if you're on any immune suppression, you can't get live vaccines, period. But I think those recommendations are starting to change. So in this study in kids, Athos Bousvaros has been involved with this work, looked at varicella vaccination in, I'm sorry, he didn't look at this one, he looked at the next study coming up. This is looking at HIV. Varicella vaccination was safe and effective in patients with HIV. Here's Athos's work, pediatric IBD patients from Boston Children's Hospital, varicella vaccination in immune-suppressed kids was safe and effective. A small study, but showed it was safe nonetheless. I think the most useful study here was this very large study looking at almost 500,000 Medicare beneficiaries with various inflammatory disorders with a subgroup of those patients on biologic therapy. Not only were there no cases of zoster in those patients taking biologics, but it did in fact show protection against developing zoster when they were vaccinated. So again, this goes against the fact that there's risk and actually shows there's protection. So as I mentioned, the infectious disease practice guidelines were just published this past week. Some of this is old, but some of it's been updated. What they teach us is that we should be thinking about immune-suppressed patients in two different buckets. One is low level, and the other are high level immune suppression. What's low level? Low level is prednisone, less than 20 milligrams a day. But then look at this, it's azathioprine, less than 3 milligrams per kilogram, or 6-MP less than or equal to 1.5 milligrams per kilogram, or methotrexate that comes out to about a dose of 25 milligrams. So actually, most of the patients, if you're using standard doses of our thiopurine or methotrexate therapy, are in the low-level immune suppression category. The high level or doses higher than that, or any biologic therapy. If you look at the recommendations on how to administer live vaccinations, varicella vaccine, if you're not immune to varicella already, is a no across the board for high-level immune suppression. Remember, on biologic therapy, the answer is no. However, they give a maybe for low level. Perhaps we should be giving this to patients based on some safety data that I've already presented, but I will tell you there's disagreement and controversy over this issue with varicella. The recommendations are a little more clear with zoster. They again give a no for high level, so biologic therapy, high-dose thiopurine or methotrexate therapy, but they give a fairly definitive yes for low-level immune suppressive therapy. This is a change in practice for me. I had been not offering these patients live vaccinations, and I think based on this and talking to my expert colleague, Dr. Gil Melmed, who's taught me about this over the past number of years, I think I will start vaccinating my patients on thiopurine therapy with zoster vaccine. The question then is, what about biologics? These are our patients who get into trouble with zoster all the time, and I'm not exactly sure what to do about these patients. There's some benefit-risk trade-off that we have to think about in our patients because this really can be a big problem. I will tell you, I emailed my colleague, Dr. Melman, about this a couple of weeks ago when I was preparing this talk. I wanted to see what he was doing, and this is actually cut and paste from the email response here. If you can't read it, this is, let's see, November 27th, 11 a.m., is what we do around. We write each other emails during the day. I have vaccinated 1 or 2 against zoster on anti-TNF when they've asked, which is much more relevant than varicella because of our patient population, but I don't quite have the cojones to do it routinely. Thanks, Gil. Sorry. Should be careful what you write. It's all searchable. Some quick pearls so I could try to finish on time here. How long do you have to wait to start immune suppression after a live virus? The recommendations are 4 weeks or longer. Never give live influenza despite the group that they're in, MMR or yellow fever. Gil told me yesterday about a patient of his who wants to travel somewhere that requires yellow fever. The answer is pick another place to go. Household contacts, this comes up quite a bit. Household contacts can receive MMR, rotavirus for infants, but wash your hands, varicella zoster, but watch for lesions. Patients who get lesions can be infective and you should stay away from them if you're immune suppressed. They should never receive live influenza or live polio that's not given in this country. What if your patient does get it? Shingles is one thing, but this is a patient of ours just over the past couple of weeks that has disseminated varicella. If you look at this close, you can see the typical lesions. Treating varicella in immune-suppressed patients is important. You have to really jump right on top of this with shingles within 1 week. With localized disease, oral medications are fine. If they have disseminated disease, you should really think highly about putting them in the hospital on intravenous drugs. Chickenpox is the same thing. Post-exposure prophylaxis, what constitutes exposure? With chickenpox, it's close indoor contact, means you're probably exposed. Shingles is contact with open lesions. Are the patients susceptible? Think about that first before we're deciding on treatment. A negative history of disease, no vaccination, negative titers are susceptible. And if not immune suppressed, you should vaccinate them within 3 to 5 days of exposure. If they are immune suppressed, think hard about getting them Varizig or consider IVIG. So to wrap up, of course we're never going to prevent all infections, but we do have an opportunity to prevent serious infections, the complications of those, by thoughtful patient selection and vaccination. We still have a lot more to learn about vaccinations. I think the next thing we really have to think about is the safety of using zoster in our anti-TNF treated population. And it's critical to have early recognition and treatment of infections in immune-suppressed patients with a very low level threshold for intervention. So thank you for your time. Honored to be here. Thank you very much.